Hello, my name is Dustin Anderson. Today I'm going to be talking about anterior cruciate ligament tears and the disablement model. Currently, I'm enrolled in the Doctorate of Athletic Training program at Indiana State University. I work as a military athletic trainer at Fort Sill with the basic training units, and I've been practicing athletic training for 4 years. So what is a disablement model? Disablement models give the clinician a way to look at an injury in a dynamic way. There's there's quite a few models out there now, but I'd like to talk about one developed in 1965 by Nagy. Nagy was a sociologist, and he recognized the importance of the environment and the family, society, and communal factors and how they all influenced disability. As you can see from the chart, it sort of follows a process, and I have definitions of these on the next slide. You can see it goes pathology, impairment, functional limitations, disability, and handicap. There's a push away from using the word handicapped. Now there's revisions with this model, and I don't think handicapped is used. But you can see the functional limitations, disability, and handicap all relate to quality of life. So the emotional well-being, behavioral, sleep and rest energies of the person. So the framework for the Nagy model is, like we see in the chart, the first is pathology. So refers to the cellular and tissue changes caused by an injury or disease. Impairment is defined as a discrete loss or abnormality of mental, physiological, or biochemical functions. Functional limitation effects manifest in the performance capacity of the person as a whole. And disability is expressed as a physical or mental limitation in a social context, the gap between a person's capabilities and the demands of the environment. So before we move on talking about the disablement model with ACL tears, let's just look at some of the common risk factors associated with injuries in general, and some risk factors for ACL injuries. So we basically have two types of risk factors: modifiable and non-modifiable. Modifiable is what the clinician can control to some extent, or not so much, maybe not control, but can work on and improve for injury prevention. And non-modifiable is outside the clinician's control, athlete's control. So some common risk factors are age, sex, fitness level, past injury, postural stability, muscle strength and balances, and reaction time. And you can read the rest of the list. Some modifiable risk factors for ACL injuries are neuromuscular control, biomechanical factors, dynamic loading, movement variability, muscle strength, fatigue, and alignment during landing and cutting maneuvers. So the next few slides, I'm just going to talk about a couple of scenarios. Scenario one is a disease-oriented approach to an ACL injury. You can think about this as the traditional approach that clinicians take when someone is injured. There's a lot of good research on disease-oriented approaches to rehabilitation, and I'll just start with the patient's demographic. He's a starting junior star running back, height 5'11", body weight 178 pounds. He's a Division I athlete, and he comes from a poor socioeconomic background, and he has a chance to go to the NFL. Just some general stuff for medical screenings: family history of heart disease, history of depression, no major injuries, nutrition habits are fairly decent, and no underlying medical conditions. You could also throw some stuff in there from the pre-participation exam if you wanted to, just for the ease of use and time limits. Those are the only things that I chose to write down. So when the athlete gets hurt, it was in the 5th game of the season. He had a patellar tendon graft, and the athlete was done for the season. And here's where it's going to become important for the disease-oriented approach. ACL rehabilitation, they just followed a traditional method for ACL injury rehab. The patient's health quality of life was unknown. Patient's feeling about the injury were unknown. Coach's opinion was unknown. Family support unknown. If a disability was formed, it was unknown. So the athlete just went through, traditional rehabilitation for the ACL injury. He came in, did his thing with an athletic trainer, physical therapist, whoever he was working with, and that was it. Just focused on the injury, got him back to a state of function, and was cleared by the medical staff to go back to participation. And I just want to note, when I say unknown, I just mean that there was no documentation taken or no way to record it. For scenario 2, a patient-orientated approach to an ACL injury. I'm not going to repeat the patient's demographic, medical screening, or ACL injury. What I do want to talk a little bit about is when we think about the patient and giving them the best care possible, some things we can do from a rehab perspective is use of PROMs, patient-rated outcome measures. Get the patient's thoughts and feelings on the process, get what the coaches are thinking, the family, the team, and we can always do that through the athlete and let them know that there's a support system there, and develop that support system through the injury. Give the athlete options to go see a sports psychologist if need be. With this, there's a holistic approach to take into rehab. We're not just worried about the physiology, the limitations of it, but we're worried about the athlete as a whole, and we take a holistic approach, not only the body, but the mind and everything else. And again, in the end, the athlete was cleared by the medical staff to go back. So there needs to be a shift in how clinicians treat injuries to ensure that injuries don't lead to disabilities. And what I mean by that is, if we use a disablement model approach, we're looking at all the facets of the injury of the athlete, just not the active pathology, the limitations, or the functional limitations, but how they function within that group as a whole. And yes, you have to start thinking of athletic teams as a social group. And if that athlete is not fulfilling those roles, or he or she doesn't feel like they're fulfilling they're roles that can lead to a disability, and it could reduce return time and their quality of life. And that's in the end, that's what it's all about, is improving the athlete's quality of life and making sure that they recover from the injury, not only physically, but mentally, and ready to go back.